Now with pleasure, we'd like to go on to our next keynote speaker. So I would like to introduce Mr. Stephen Halcrow. Mr. Halcrow is a Sydney University medical graduate who worked briefly in the industry of occupational health. Thereafter, he underwent a period of general surgical training, followed by neurosurgical training in the British NHS in the 1980s. The highlight of his neurosurgical training was over 3 years working in Belfast in Northern Ireland during the protracted period of sectarian violence, commonly referred to as the Troubles. Mr. Halcrow completed his Australian neurosurgical training in Sydney and was a staff specialist and VMO neurosurgeon in Adelaide and Canberra. His subspecialty interests include cerebrovascular, tumour, peripheral nerve and plexus surgery. Mr. Halcrow retired in 2018. So please welcome him now for his presentation.
Thanks, Laura. Can you hear me?
Yes, we've got you.
Unfortunately, I found out my web camera doesn't work at the practice session yesterday afternoon, but as long as you can see my slides, that's important. I don't look too good at this time in the morning anyway.
We can't quite see the slides as yet. Tess, are you able to help us out with that?
How's that?
Still not up. If you have your quick share screen on
Right, yeah.
So down in the bottom middle, it should say share screen.
It's turning out to be a disaster.
Have you got the Zoom program up on your screen, and then down in the middle of the screen there should be a green highlighted share screen icon. Can you see that?
Oh, yes.
Yeah, if you click on that one, hopefully that should bring up your presentation. And so now your screen's showing. So if you load your PowerPoint. Fabulous. There you go. We're in business.
Good, finally. Well, thank you for inviting me to talk today. The answer to these two questions is yes, with some difficulty. It's really the art of teaching old dogs new tricks, or rather, old dogs learning new tricks. I'd like to state from the outset that this lecture is not a scientific or even a quasi-scientific dissertation, but merely the musings of a retired surgeon. I can only comment from my own personal perspective of a neurosurgeon approaching retirement, the associated exigencies of maintaining professional knowledge and skills, and of the acquisition of new skills as such as required. Nothing earth-shattering about this. Other surgeons in similar positions to myself will, of course, have their own unique sets of issues to deal with in their own particular ways. I'd like to divide the talk firstly into the potential problems that senior surgeons may or will have to deal with in their clinical practices, and what I personally found a benefit to myself, and secondly, if we've got time, the issues surrounding retirement, age and reasons to do so, and those to continue in the surgical and or medical workforce. This is a list of some of the problems that may confront the ageing surgeon. It is by no means fully comprehensive. Although I intend to focus mainly on that of acquiring new skills and adapting to technological change, the others are still worth briefly mentioning. By remoteness of education, this refers to the fact that the older the surgeon, the longer he or she has been from his initial surgical education and training, then the shorter it was likely to have been. Furthermore, the less likely it would have been that this surgeon would have been required to complete any formal research requirement or post-FRACS fellowship training. Although I did my initial neurosurgical training in the British NHS, My subsequent advanced training in Australia was still only 4 years in duration, and without a compulsory research year or requirement to obtain a higher degree. Similarly, there was no compulsion to do a post-qualification fellowship training period, although it was considered desirable. These lack of compulsory requirements have since changed, and advanced neurosurgical training has been extended to 5 or 6 years duration before eligibility to sit the final fellowship examination. The neurosurgical training in my era was fairly low tech and heavily intracranially orientated. Instrumented and complex spine surgery was not addressed at all. It was virtually the sole domain of spinal orthopedic surgeons, and who tended to also exclusively occupy the various spinal units, with only the relatively few exceptions as taken neurosurgeons. This too has changed more recently. And it is with instrumented spine surgery in particular I've had to learn, adapt to and upskill in since coming to Canberra. Being close to the ski fields and major interstate highways has brought multiple referrals of acute spine trauma, and which is dealt with mainly by the neurosurgical department at Canberra Hospital. Maintaining surgical knowledge, of course, melds with new skills development, as it remains necessary for all surgeons to keep up to date with the extraordinary profusion of technological changes that have come in the rapid wake of the exponential expansion of the computer-driven age over the last few decades. I'll discuss age-related changes in the final section on retirement issues. This is a list of useful teaching and learning aids that I've utilised. In getting up to speed with spinal instrumentation, particularly the tricks of the trade in safe pedicle screw placement, I've found attending specific surgical workshops, and in particular learning directly from younger colleagues who have been trained in these techniques from an early stage, to be of most overall benefit. The hands-on approach in cadaver dissections at workshops provided an excellent introduction to the trials and tribulations of safe pedicle screw placement. Specific how-to operative surgery texts and some journal articles were of some use, as indeed were some YouTube videos. The latter is the general go-to site for all matters of how to do in life, and surgical procedures are also covered in unexpectedly good detail. I didn't find confidence of much use in general terms. As an example, the last 2 books in the theme series I found of particular help, particularly the last one on tricks of the trade in doing spinal surgery. But the first on operative neurosurgery from the Robin Smith series is now well outdated and of little use. These are some of the new surgical and imaging procedures that I've had to learn and adapt to as an ageing consultant over the years of my practice. As previously mentioned, complex and instrumented spine surgery was for me personally the most challenging and at times frustrating, as I really had to learn it from scratch, but I'd already been a consultant for many years beforehand. Magnetic resonance imaging. You're probably wondering why I listed this under this heading. Quite simply, because it was not an available imaging technology during my training. I had to learn it as a newly qualified consultant. My initial training in neurosurgery was in the British National Health Service, and this fell at a transitional period between the times of highly invasive and subsequent progressively non-invasive neuroradiological imaging. Pneumoencephalography had been supplanted by the advent of CAT scanning, so named initially because only axial slices were available, and NMR imaging, nuclear magnetic resonance imaging, as it was originally termed, was still in its infancy and largely unavailable for clinical use. The very first CAT scan worldwide was performed on a patient at Atkinson Morley's Hospital in London in October 1971, when I was a first-year medical student. And the first CAT scan was installed in Sydney, Australia in 1977, the year of my internship. The first NMR scanner in the UK was installed at the Hammersmith Hospital in London in 1981, with only a 0.15 Tesla cryomagnet and and one of the very few next to be installed was at the Institute of Neurological Sciences at the Southern General Hospital in Glasgow, where of course the Glasgow Coma scores and scales came from. In 1984, when I started my neurosurgical training. All I had was two first-generation EMI rotate translate single slice CAT scanners, which were really very slow, each image slice acquisition taking up to 5 minutes. Furthermore, access to CT was severely restricted and then rationed for emergency use in the very few hospitals where it was available at the time. This was the main trauma hospital in Northern Ireland, where the neurosurgical unit was located. There were only 2 CT scanners in Northern Ireland at the time, one at this hospital and another at the Belfast City Hospital for exclusive use by the oncology department. The RV8 CT scanner provided after-hours emergency imaging, but this was severely rationed, rarely immediately available, and with strict criteria for its use. As such, the only ubiquitous after-hours imaging was a set of plain skull and cervical spine X-rays. Consequently, many acute comatose head injuries were still managed on the basis of clinical indicators, present or absence of skull fractures, possible midline pineal shift, and exploratory burr holes. There was no MR at all, and after-hours cord and quarter equina compressions were investigated with basic contrast myelography alone. This is the sort of thing we got to deal with. And as you probably noticed, that thing there is a bullet in that set of skull X-rays. This rather crude and prototypical looking device is the UK's first Nmr Scanner, the low-field 0.15 Tesla cryomagnet. It was initially used for research, setting baseline parameters for brain imaging anatomy. Its only clinical use at that stage was in looking for plaques in demyelinating disease. MR spectroscopy and functional MRI would only come much later on with the advent of more commonly available high-field magnets and sophisticated software developments. At the time, there were journal articles discussing terms such as T1 and T2 weighting of images, inversion recovery and spin echo sequences, but none of us really knew what any of this meant. By the time I left Belfast at the end of 1988, there were still no MR scanners in all of Ireland, and still very few available for clinical use in the remainder of the UK. MRI only became readily available for clinical access and use in the 1990s and in the later 1990s in Australia. In 1998, there were still only 38 MRI scanners nationwide in Australia. Interoperative MR and CT. Interoperative MRI has been available in the ACT at Canberra Hospital since 2010, as its greatest use in the removal of pituitary and other deep midline located intrinsic brain tumours, and is relatively straightforward in its use and application. Interoperative CT probably has its greatest application for this device called the O-arm, for fairly obvious reasons. An instrumented spine surgery when coupled with frameless stereotaxy to allow virtually near perfect placement of pedicle screws, thus significantly both improving patient safety and obviating the need for subsequent screw revision. This shows the surgeon, in this case Dr. Michael Oyang, an excellent spinal neurosurgeon, inserting a pedicle screw at the L4 and L5 levels using this device, the Stealth Station, the overhead camera, reference to this reference frame with all fiducials. This is the device to insert the pedicle screw. As you can see, they've been placed in very good position on the axial and sagittal reconstructions at the L4-5 level from L4-5 lift. Image-guided surgery. Frame-based stereotaxy has been around since the middle of last century, but frame-less stereotaxy using surface mapping and stick-on fiducials was only introduced for clinical use in the 1990s. It required adaptation to fairly intuitive computer programs. This technology was fairly easy to learn and has virtually supplanted frame-based stereotaxy, with the exception of functional work movement disorders where high accuracy neuroablation and insertion of electrodes for neurostimulation is required. These remain highly subspecialised procedures and are limited to a relatively small number of neurosurgical units. Stealth and Brain Lab are the two commonly used frameless stereotactic systems in Australia. And this photograph shows the Stealth system station with the overhead camera, which is that. It detects both the reference frame, fixed either to the patient's head for cranial cases, or directed to a spinous process for spinal cases, and appropriate points the anatomical point to be referenced. Both systems are very user-friendly and easy to use. Minimally invasive surgery, this has been the general trend in surgery in general. In neurosurgery, this is extended to stereotactically localised mini craniotomies, endoscopically assisted surgery, and percutaneous insertion of pedicle screws as some examples. The redoubtable Dr. Charlie Teo has personally pioneered the use of endoscopically assisted neurosurgery in Australia and has run regular workshops to pass on these useful skills. As previously mentioned, acquiring these particular skills has been the most challenging for me personally. I had to start utilising these relatively late in my career for reasons previously stated. Learning from younger colleagues, most of whom had acquired these skills from overseas training fellowships, was personally most useful for me, as well as utilising the stereotactically assisted intraoperative CT scanning O-arm, which is the single most useful piece of recent technological advance currently available for pedicle screw placement. These last three skills all require specific subspecialty training and are not really relevant to new skill acquisition by older consultants. We all use standard scale-based approaches, but these listed here are of an advanced nature requiring extended subspecialty training. I've still got a bit of time. I'll just briefly discuss retirement issues since I've been retired for several years. So if we're going to retire, what particular age should we do so? There are cases both for and against a fixed age for retirement of surgeons. Continuing ability to perform both physically and cognitively at any given age is probably of greater importance and relevance than age per se. Hence, physiological age is probably of greater importance than chronological age, with some surgeons still performing better at age 70 and others at, say, age 60 years, all factors being equal and taken into account. Stewart and Bismarck, in a study on performance of the ageing surgeon, published in the BMJ last year, indicated that about 20% of Australian and New Zealand surgeons and almost as many Canadian surgeons were still in active clinical practice at and after 65 years of age, but that only 9% of British surgeons were. The latter is probably accounted for by the fact that, unlike Australia, New Zealand, Canada and the United States, the UK has compulsory retirement of surgeons from the NHS at 65 years and from private practice surgery at age 70 years. Richard Robert, in a study published in the Journal of Neurosurgery in 2004, polled 29 academic neurosurgeons in the US about retirement issues and found that many were retiring about the age of 60 years. This was a statement allegedly made by Dr. Michael DeBakey when he was 91 years of age. So if there's an overall upper age limit for safe surgical practice, what approximately should it perhaps be? The renowned American cardiac surgeon Michael DeBakey, who apparently was still operating at the age of 91 years, evidently was of the opinion that age per se was not necessarily a factor of great importance. He was an exceptional surgeon by all accounts, but I would seriously doubt that more than a handful of surgeons could be considered safe and competent at that age. So then, why retire? Certainly currently only the United Kingdom has a policy to compulsory retirement ages for surgeons. Robert's paper in the Journal of Neurosurgery, where he sent questionnaires to 29 academic neurosurgeons in the US, found that reasons for retirement amongst this group included decreasing personal satisfaction and financial rewards, desire to pursue other activities, local ground rules mandating age-specific retirement, the general sense that enough is enough, but that overall strong desire to stop performing surgery while at the top of one's game. Spending more time with family and friends, as well as continuing existing and developing new outside interests, are obviously reasons to consider retirement, as of course is deterioration of one's health. Well, retirement may not be possible for a number of reasons. Perhaps the worst is poor finances, either as a consequence of the fallout of several failed marriages with ongoing financial obligations, or previous poor investment strategies with ongoing significant debt to be repaid. Many men identify with their work, with the work they do, and male surgeons are certainly no exception in this regard. Retirement can therefore lead to losses of sense of worth and self-esteem, fear of losing one's standing in the community, both the medical and the general community at large. Failure to plan retirement, along with lack of other interests, can put off the decision indefinitely until external factors force the issue in invariably a rather ignominious fashion. In other words, the feared tap on the shoulder. With the current numbers of trainees, lack of replacement should no longer be a valid reason not to be able to retire. Staunch resistance to change remains a strong impediment to the decision to retire a smaller number of rather willful individuals. So why should we retire? Well, we all age. Advancing age generally leads to decline in hearing, vision, manual dexterity, and finally cognition, all of which are compensated for by increased experience for many years. Eventually, however, we all succumb to one or more of these over time, and retirement is forced upon us. There are, of course, parallels with the aviation industry, where pilots are required to demonstrate their continuing competence with testing in flight simulators. Commercial pilots in the United States have a statutory retirement age of 65 years and are no longer allowed to pilot commercial aircraft. The only statutory requirement ages currently in Australia are for federal court judges at age 70 years under Section 72 of the Australian Constitution, and Defence Force personnel, 60 years of age for full-time personnel, 65 years for reservists. So, in summary, none of us are indispensable. There are always younger people who are possibly quite better to come along and replace us. There's a term, there are old pilots and bold pilots, but there are no old bold pilots. As such, there are old surgeons and bold surgeons, and there are unfortunately still old bold surgeons. Perhaps time they should consider retiring. So retire at the right time, go out at the right time at the top of your career, enjoy retirement, and hopefully you'll live long enough to do so. Thank you.
Thank you very much, Mr. Halcrow, for that discussion. It's quite remarkable to think that your career has spanned at a course where there was no pre-operative imaging, and what courage that would have taken as a surgeon to operate, particularly in neurosurgery, without the insight of imaging, to the period where you were trained yourself in the use of stereotactics. It's quite remarkable, really.
God.
So we have a few questions. The first from Dr. Bandy. She said, thank you, first of all, and also, how do you satisfy yourself that you are remaining relevant with your skills? Do you recommend taking on new technologies as they are spruiked by industry, or do you take them on too early or wait until subjective evidence amounts? And at that stage, are you actually too late?
Well, I don't have any skills anymore because I've retired, but I think we just assimilate them by osmosis. I mean, all these things are well and truly developed before they come on the market, and obviously, and I think from my own perspective, it was a case of picking and choosing what would be useful for me in my practice, and hopefully learning them to the best of my ability. But the problem is that there's been such a profusion of technology, not just over the time of my consultancy, but it's ongoing. And I think we all have to play catch up to a certain extent and use that which is going to be of benefit to patients in particular, and also to us.
And I guess there also is the question of, as new technology becomes available, what is the access to all consultants to that technology, such as robotics, where you don't have them in every single centre? So I guess that becomes a new challenge for generations to come as well, in how to make sure their skills are current and have access to the right technology. Professor Solomon has asked, what is the role for non-operative contributions such as teaching, skill teaching, or clinical committees in retirement?
Well, first of all, g'day, Mike. I remember working with you many years ago at Prince Alfred. Well, yes, I think in retirement, teaching gratis medical students and registrars is very satisfying. I'd be very happy to do that. But it comes a time when I'm basically a dinosaur and I don't become relevant anymore. But while I can contribute, I'd be very happy to do so.
Excellent. Well, thank you very much for participating today, and it was very insightful.